Assalamu alaikum wa rahmatullahi wa barakatuh. Today we're going to talk about the introduction to the musculoskeletal tumors. This is the first lecture in a set of lectures designed for the discussion of the musculoskeletal tumors, include the introduction, the benign and malignant bone tumors, and another lecture for metastatic bone tumors and multiple myeloma. My name is Yasser Abed. Knowing as much as possible about your enemy precedes successful battle, and learning about the disease process precedes successful management. Knowing as much as possible about the tumor will help you in the management of the tumor and the best treatment possible for your patient. Primary bone tumors is a rare tumor. It's less than 1% of the total human tumor burden. The primary malignant bone tumor consists 1% of all malignant bone tumor, and sarcoma usually metastasize through the blood. Most of this tumor has male predominance except for giant cell tumor and aneurysmal bone cyst. The primary bone tissue tumors is a mesenchymal derived tumors. It's from the mesoderm. It's either benign or malignant. Malignant is called sarcoma. Sarcoma means in the Greek language flesh or fish flesh. Sarcoma is characterized by the ability to have systemic metastasis and local invasion to the nearby tissues. It's derived from primitive pluripotent mesenchymal cells, which can form bone, cartilage, fibrous tissues, lipogenics, blood vessels, nervous tissue, and small round blue cell tumors. And this is the basic principle for the classification of bone tumors according to the nature of tissue format. So based on the tissue of origin, either bone, cartilage, fibrous tissue, bone marrow, blood vessels, or mixed tumors, or tumors of uncertain. The broad classification of bone tumors include primary bone tumors, metastatic tumors, and tumor-like lesions. Tumor-like lesions including bone cysts, various types, and the fibrous dysplasia. The cytic lesion but does not have actual tumor tissues inside. The metastatic bone tumor is a different entity from primary bone tumor. It's tumor arising from distant site like liver or lung and sent to the bone. It's more common than primary bone tumor with different diagnostic tools, different management strategies, and different survival and different prognosis than primary bone tumors, and will be discussed separately. The primary bone tumors either includes tumor that originates from the bone tissues, including benign like osteochondromas, osteomas, and chondromas, malignant like osteosarcoma and chondrosarcoma, or tumor that arises from the bone-affiliated tissues. The benign form like adamantinoma, the malignant form like Ewing sarcoma. The bone-forming tumor in the benign forms like osteoma or osteosteoma, malignant like osteosarcoma, different types. Cartilage-forming tumors, benign like enchondroma and osteochondroma, malignant like different forms of the chondrosarcoma. Fibrous lesions, benign like non-ossifying fibroma and fibrous dysplasia, malignant like fibrosarcoma and malignant fibrous cytoma. Round cell tumors, benign like eosinophilic granuloma, malignant like Ewing sarcoma. Giant cell rich lesions, benign like giant cell tumors and aneurysmal bone cyst, malignant like the malignant form of giant cell tumor, vascular, etc. For the evaluation of bone tumor, we have to cover 4 items, including adequate history taking, careful physical examinations, using the investigations tools available, including lab, and we'll focus on the imaging modalities, and finalize your evaluation by performing biopsy if needed. This is an analytic approach for the evaluation of bone tumors. This will help you how to think to reach a differential diagnosis. You have to consider the age of the sex of the patient because the bone tumor is known to have certain predilection for certain age. You have to mention is it single or multiple. You have to mention which bone is affected, so the location of the skeleton is very important. And also the location within the bone itself, which part of the bone is affecting. Is it the epiphysis, the metaphysis, diaphysis? Is it central, eccentric? Then you have to describe the morphology of the bone tumor on X-ray, focusing on the border of the lesion, the nature of the bone destruction, the presence or absence of periosteal reaction, presence or absence and nature of the matrix, which is the tissues produced by the tumor, the presence or absence of soft tissue masses. As we mentioned before, bone tumor have certain predilection for certain age. For example, if you look for the metastatic lesions, metastatic bony lesions usually affect old age after the age of the 45 or 50. Also, the benign lesion is usually located within the first 3 decades of life. The primary malignant bony lesions usually affect the first and second and to some extent the third decade of life. So if you have a patient with lytic lesion from the femur, for example, and this patient is 80 years old, the first differential diagnosis cannot be primary osteosarcoma. You have to mention that is the first differential diagnosis is metastatic bone disease, and vice versa. If you have a lesion in the femur in a young age, 20 years or so, so the first differential diagnosis is primary bone tumor rather than metastatic bone lesion. So it will help you to narrow your differential diagnosis and to reach a diagnosis at the end. The symptoms of the bone tumors can vary from one patient to another. Usually pain is the common presenting symptoms. The presence of swelling usually is not visible due to the muscle covering. However, in large-sized tumors and in tumors that have certain prominence, swelling will be the presenting symptom. Most of the cases will report a history of trauma. Usually it will be trivial, and usually it will be the cause for discovery of underlying bone lesion. Also, the patient can be presented with neurological symptoms, like if you have a lesion in the spine with neurological compression to the patient, can be presented with paraplegia or quadriplegia or symptoms of nerve compression. Things can be more complicated. The first presentation can be in the form of the pathological fracture, which is fracture through weakened bone by trivial trauma. Also, patient can be presented with effusion of the nearby joint and presented with deformities. This is characteristic of the multiple hereditary exostosis in which there are multiple deformities. Rarely bone tumor can be presented with lymph node enlargement. For the imaging evaluation, we have different modalities that we can use for evaluation and diagnosis of bone tumors, including plain X-ray, CT scan, MRI, radionuclide scanning or bone scan, and the most advanced and most expensive investigation tool is the PET scan or the positron emission tomography. We have to know the basic principle of each of these investigation tools and have to know the indications and what information can be gained from these investigation tools. They are like complementary to each other, and you cannot use one alone in isolation of the others. Each one complete part of the picture. It's like a puzzle, and each of them will fill a defect or a gap, reaching to a differential diagnosis at the end. From the plain X-ray, you can gain the site of the lesions, the border of the lesion, or the zone of transition, which is the border between the tumor tissues and the normal tissues, the nature and extent of the bone destruction, the presence or absence and the nature of the periosteal reactions, presence or absence and the nature of the matrix produced by the tissues, and also the nature and extent of soft tissue involvement of the tumor itself. This is a schematic presentation to summarize what you have to comment on in the plain X-ray. You have to mention the border of the lesion. You have to talk about the matrix nature. Is it cartilaginous or bone? You have to comment on the periosteal reaction. Is it interruptive or solid periosteal reaction? You have to comment on the nature of bone destruction, geographic, not eating, permittive. You have to comment on the multiplicity of the lesion, single, multiple. You have to comment on the presence or absence of soft tissue extension, and you have to mention the site of the lesion. Is it epiphyseal, metaphyseal, or diaphyseal? Certain tumors have favorable sites for its development. For example, parosteal osteosarcoma is famously known to affect the posterior aspect of the distal femur, whereas chondroblastoma, which is a benign cartilaginous tumor, usually affect the epiphysis of the long bone before skeletal maturity. Adamantinoma, on the other hand, is known to have certain affinity for the chain of the tibia. Also, the location in relation to the central axis of the bone, especially in wrong tubular bone, either it's central or eccentric. Central located lesions like simple bone cyst and enchondroma. Eccentric location is noted with the aneurysmal bone cyst and non-ossifying fibroma and giant cell tumors. These are X-ray examples for the site of the lesions. The one on the left is the distal femur, showing sclerotic lesion on the surface of the back of the femur. This is a common location for the parosteal osteosarcoma. In the middle picture, you have a lytic lesion affecting the epiphysis of the proximal tibia in skeletally immature child with clear, demarcated, well-defined border with geographic bone destruction and presence of minute calcification inside the lesion. Usually, this is a location for the chondroblastoma in that age. The X-ray on the right showing multiple lytic lesion affecting the cortex of the chain of the tibia, and this is a common location for adamantinoma. The location of the tumor is also affecting the spine. So in the posterior element of the spine, which is a cortical in nature, usually is a common location for benign lesions like osteoblastoma, osteodystoma, aneurysmal bone cyst, whereas the anterior part of the spine, the body of the spine, which is a cancellous bone, is a common location for malignant lesions like METS, osteosarcoma, Ewing, myeloma, and lymphoma. The margin of the lesion have three types. Either it's sharp demarcated by sclerosis, sharp demarcated without sclerosis, or ill-defined margin. The slowly growing lesions have usually sharp sclerotic border. Usually it's a benign in nature, like non-ossifying fibroma. When the border will be ill-defined, this is a typical for malignant or aggressive lesions. However, in certain tumors, malignant bone tumors after radiation or chemotherapy will show some sclerosis and narrow zone of transition of the tumor due to good response to chemoradiotherapy, and this is a good prognostic sign. This is examples for the border of the lesion. For the sclerotic border, the one on the left, X-ray on the left, show well-defined sclerosed borders of a benign looking lesion, whereas on the X-ray on the right, there is ill-defined lesion affecting from the superior piriformis floor of the acetabulum and iliac bone. You cannot define the boulders, we have no sclerosis around. Usually this indicates malignancy. The bone is destroyed by either of two mechanisms, either by direct effect of compression by the tumor cells or by increase in the osteoclastic activities locally. So there is activation of the osteoclast through a complex mechanism that increases to more destruction. The cortical bone destruction is less rapidly affected than the trabecular bone. However, the loss of the cortical bones appear earlier on X-ray due to the contrast between destroyed bone and the normal bone, whereas 70% of the trabecular bone should be destroyed in order to be visualized on X-ray. Bone destruction can be classified into geographic, which is characteristic for benign lesions, mouth-eating, and permeative, which is characterized for rapidly growing infiltrating malignant lesions. You can see on this slide the different types of bone destruction. The one on the right is the giant cell tumor showing geographic destruction of bone lesions, well-defined lesion continuous to each other. The one in the middle is the multi-eating appearance, where you have racked and multiple small areas of destruction. The one on the right is the permeative. It's like an Ewing sarcoma, small areas of bone destruction confluent together. Both multi-eating and permeative types of bone destruction is characterized for malignancy. Also, the periosteal response and the pattern indicate the biological activities of the lesions. When the periosteal reaction is uninterrupted, continuous, usually this will be a benign tumor. When it is interrupted or discontinuous, this usually will indicate the malignant process. Periosteal reaction can be defined with any widening or irregularity of the bone contour. So any cross on the surface of the bone is a periosteal reaction. The uninterrupted periosteal reaction indicates a long-standing benign process, whereas the interrupted periosteal reaction, like sunburst or onion skin, indicates a malignant process. This is a schematic representation of the different types of periosteal reactions between uninterrupted on the left and interrupted periosteal reaction on the right. This is an X-ray examples for the sunburst osteosarcoma on the left. You can notice that there is presence of abnormal mass on the surface of the bone with hair-like calcification alongside the elevated periosteum and calcification along blood vessels. This is characteristic but not diagnostic of osteosarcoma. The one in the middle and in the far upper right is an onion skin lamellated periosteal reactions, indicate multiple periosteal reaction. This is characteristic but not diagnostic for the Ewing sarcoma. The Codman triangle indicates that there is periosteal reaction that was destroyed by the tumor, and the remaining triangle here is indication for the remnants of the periosteal reaction. So imagine on the first one on the left that the areas of calcification in the middle are destroyed, and the remaining triangular proximal part, this is the Codman triangle. Also, the type of the matrix production represent the intracellular material produced by mesenchymal cells, either bone, cartilage, exoid, collagen, whatever. The type of the matrix allow for differentiation of some similar appearing, like differentiating bone from cartilage. The presence of calcification of the tumor matrix indicate cartilage tissues. Some periosteal reactions are completely radiolucent, like fibrous lesions, or like the tumor-like lesions like single bone cyst. These are X-ray representing the osteoclastic matrix where there is bone formation. On one on the left there is intramedullary calcification and bone formation. And the one in the middle, upper middle, is the sacrum, where is this tumor formation, bone formation. The third one is a huge mass of bone formation on the posterior surface of the femur, famous to be a parosteal osteosarcoma. The difference between calcification and ossification. Calcification means the position of calcium in abnormal locations, whereas ossification is bone formation. Calcification is the radiological landmark for cartilaginous tissue formation, because cartilage by its nature is a radiolucent material and can be only visible if there is deposition of calcium inside. This X-ray represents inchondroma, whereas the other one indicate chondrosarcoma. The presence of soft tissue mass is somewhat a tricky question. Is the soft tissue mass coming from the bone, or is the soft tissue mass is invading the bone? So how to differentiate? We have different types of soft tissue mass associated with bone tumors, either arising from the bone or invading the tissue. And this is the difference between primary soft tissue tumor invading the bone and primary bone tumor with soft tissue extension. So to sum up the previous slides, the benign lesion usually will have a well-defined sclerotic border, have a geographic nature of bone destruction. The periosteal reaction, if present, will be solid or uninterrupted, and usually we have no soft tissue mass. Whereas malignant bone tumor usually will have a poorly defined borders with wide zone of transition, have a large area of bone destruction in the moth-eating permeative form, and the periosteal reaction, if present, will be interrupted, some periosteal onion skin appearance with soft tissue mass. To grade bone sarcoma, you have to comment on the cellularity, the nuclear feature, the mitotic figures, and the presence or absence of necrosis. The grading of soft tissue will correlate with the prognosis of the tumor itself, like in chondrosarcoma or malignant vascular lesions. Some lesions are not amenable for histological grading, like Ewing sarcoma, multiple myeloma, and lymphoma. Some lesions are always high grade. Sometimes it's not useful in predicting prognosis, like adamantinoma or chordoma. The grading of bone sarcoma will determine the type of the lesions, determine the prognosis, so help you in planning the treatment, guide your treatment lines, help you to compare results between different studies, and define both the local and systemic spread of the disease. To be able to perform the grading of the bone sarcoma, you have to do what's called the staging studies, including the plain X-ray, the MRI, the CT scan, chest CT, bone scan, PET scan, or SPECT CT. In the conventional X-ray, to comment on the cortical destruction, the presence of periosteal reaction, the involvement of joint space, the multiplicity of the lesion itself, the matrix productions, which type of bone is affected, which part of the bone is affected, and relation between the bone and surrounding tissue. You can gain this information from X-ray, as mentioned before. The second useful tool in the management and the diagnosis of bone tumor is the magnetic resonance imaging. It measures simply the water content of the tissues. It can evaluate the entire bone and adjacent joint and soft tissue. Best imaging modalities for the intraosseous and soft tissue extent. It can diagnose skip lesions, which are in areas of bone tumor not in direct relation to the primary one. So if you have a lesion in the distal femur, you can have a skip lesion in the proximal femur, not in continuity with each other. Also, the MRI is useful for evaluation relation of the tumor to the neurovascular structure, so help you in planning for the treatment and the biopsy track that you will need it on. Sometimes, with experienced radiologists, you can mention the pathology according to the signals emitted by the MRI. Not that accurate, but can help you. On the MRI image that presented on your right side, this was done for low back pain as regard the disc prolapse or degenerated disc, and accidentally discovered to have a lytic lesion in the sacrum that appears on the white line here. CT scan can be used in evaluation of bone destruction, like this imaging to show the destruction of the body of the pubis, and can be used for detection of chest metastasis. The bone scan in which you inject radioactive material, usually it's technetium-99, and this radioactive material is uptaken by the areas of high blood flow. So on the example on the lower right, you have a black patch affecting the metaphysis of the distal femur in a child, because these small black lines on the end of the bone are the epiphysis, and epiphysis is known to be metabolically active with high blood lesion. Also, the bone scan can detect the entire skeleton, have single or multiple metastases, the activity of the lesion itself, and the presence or absence of skip lesions. So for staging of bone tumor, we have the Enneking criteria for staging of bone tumors. Have the benign form. Stage 1 is latent, stage 2 is active, stage 3 is aggressive, and for the malignant tumors we have multiple staging system, include the TNM staging system, the American Joint Committee staging system, and the most commonly used, most famous is the Musculoskeletal Tumor Society staging system, which is the Enneking staging system. Enneking is introduced a staging system for the tumor and also a staging system for the surgical procedures. The local procedures for the resection of the tumor can be intracapsular when you go through the lesion itself, or can be marginal where you just touch the lesion, or have a wide resection when you remove a cuff of normal tissues around the tumor, or be radical when you resect the entire compartment of the lesion. Of course, the rate of local recurrence, if you're talking about malignant lesion, will be more common, 100% with the intralesional, common with the marginal resection, less or remotely with the wide resection, less with the radical resection. So the more you remove, the less local recurrence you have. He also classified the amputation as a method of treatment. If you go through the lesion, it's intralesional amputation. If you go just close to it, it's marginal. If you have a normal cuff tissue between the lesion and the amputation level, it's wide amputation. If you remove the entire compartment or this articulation, this is radical form. And of course, local recurrence can occur with the interlesional and marginal amputation. For the benign tumors, Enneking divides stage 1, which is latent, to have a well-defined margins with gross loss rate and can heal spontaneously, like osteodystioma and non-ossifying fibroma. And the rate of local recurrence after intracapsular resection is very low. The stage 2 is an active lesion. We have a progressive rate of growth limited by the natural barrier, so it will be confined to the bone and not go into the soft tissue. It will have a well-defined margins but may expand or thin the cortex like the aneurysmal bone cyst. Have low rate of local recurrence after marginal excision. Treatment is marginal resection. Stage 3 is the aggressive form. The growth of the lesion is not limited by the natural barrier like giant cell tumor that can go into the soft tissue. Some forms of the giant cell tumor will have metastasis, have very high rate of local recurrence after intralesional excision, and extended resection is preferred. This is the summary for the benign. For the latent, it remains static and heals spontaneously. Active have progressive growth rate limited by the natural barrier. Aggressive means progressive growth rate invasion not limited by the natural barrier. Enneking divided the malignant lesions to incorporate three items: the degree of differentiation, or between brackets the degree of malignancy. Stage 1 is a low grade and stage 2 is high grade. The local extent of the tumor. If the tumor remains confined to single compartment, like the bone for example, it remains an intracompartmental and you give letter A for it. If this tumor extends beyond its compartment, extracompartmental, and it's B. And the third item is the distant absence or presence of metastasis. So according to Enneking, the low-grade bone tumor include the low-grade chondrosarcoma, secondary sarcoma on top of another cartilaginous lesions, the parosteal osteosarcoma, and adamantinoma. The high-grade includes high-grade chondrosarcoma, conventional osteosarcoma, Ewing sarcoma, malignant fibrous histiocytoma, and angiosarcoma. So it's easier to memorize the low-grade lesions as 2 chondrosarcoma, 1 osteo, and adamantinoma. So this is the Enneking classification for both benign and malignant. And the malignant stage 1 is the low-grade malignancy. A is intracompartmental, B is extracompartmental without metastasis. Stage 2 is high-grade tumors. A is intracompartmental and B is extracompartmental with no metastasis. Stage 3 is any grade, any site, but have regional or distant metastasis. To criticize the valuability and the usefulness of a classification system, it has to have a direct impact on the prognosis of the management and on the treatment modalities. So this is one study comparing the survival of more than 200 patients of primary bone sarcomas, and when they measure the survival rate, it arranged itself according to the Enneking classification system. So the patients with 1A, which is low-grade intracompartmental, had 5-year survival of 100%. On the other hand, stage 3 lesions had 0% survival rate at 5 years. So patients with metastasis usually will have very low 5-year survival, and according to the pathology and to the legal extent of the lesion, the survival will differ according to its classification. Another classification system is the American Joint Committee. It's not commonly used as the Enneking. It's similar but has defined the size of the tumor and the presence and the location of the distal has more details, but has no superiority than the Enneking classification. After you have performed your staging modalities, taking good history, examine the patients, you may need a bone biopsy to confirm your diagnosis. The bone biopsy have different types, either needle biopsy, core biopsy, and surgical biopsy, either incisional or excisional. The needle biopsy, it's like its name implies, it's using a needle where you can take part of the tissues, usually cells only, and it can detect malignancy or not, but not the nature of the tissue itself, and it's difficult with hard structure like a bone. Core biopsy, in which you take a core of the tissues where you can provide both cells and tissues, you can diagnose the type of the lesion itself. And we have incisional biopsy where you open and take part of the biopsy. However, in certain cases, Primary resection instead of biopsy can be performed, especially if the lesion is very small, less than centimeters, but when it is located superficially and has high likelihood to be benign. Also, patients lesions in expandable bone, like in the proximal fibula, distal ulnar scapula. This is an example of transient tumor of the distal ulna. It was managed primarily by resection of distal ulna. And this is another example of transient tumor of the proximal fibula and was done by primary resection. The principle of the bone tumor biopsy it's done only after evaluation and imaging is complete. So after finishing the investigation, you then resort to biopsy if needed. Because the imaging modalities will determine the characteristics and local extent and the systemic extent of the tumor itself. Also, staging modalities will help determine the exact anatomical approach to the tumor, which part I'm going to take the biopsy. Also, the biopsy itself will have an impact on the radiological investigation. So if I took biopsy before doing MRI and bone scan, it will give me false results. The second principle is to place a small incision whenever possible for the skin and the capsule. So it's a small area that you're gonna take the biopsy from. Also, the biopsy tract from the skin down to the lesion is considered to be contaminated with tumor cells. This is why the biopsy tract should be excised with the tumor later on. The fourth principle is that the surgeon that will perform the biopsy should be familiar with the incisions of the future surgery, either limb salvage or amputation. And also, the one who will take the biopsy should be the one who will be involved in the final management. This is an example of a poorly placed biopsy tract. On the image or the clinical photo on the left, this is a biopsy tract placed directly through the patellar tendon. And so when I'm going to perform a resection of the proximal tibia, I will have to remove the patellar tendon along with the tumor because it's contaminated. This picture on the right, poorly placed biopsy tracts through the quadriceps tendon. So with resection of distal femur, I will have to remove the quadriceps tendon. The one on the bottom left is an example of an image-guided, CT-guided biopsy, and he performed a direct posterior approach to make biopsy of the lesion. And in this approach, he violated and contaminated all the important neurovascular structures in the posterior compartment of the back of the knee. And so this will make it difficult to make a limb salvage surgery because all the structures will be contaminated. To clarify it, this is the form of resection of the distal femur, in which this is the articular surface, this is the area of the tumor, this is the biopsy tract, excised in one mass together with the excised material. The biopsy, misplaced or mispracticed biopsy, is one of the causes of failure of limb salvage because you have contaminated much tissues and you cannot remove it with resection, or you don't know that you contaminated these lesions and you will not remove it with resection later on. Sometimes we have to use a tourniquet. Tourniquet is a medical equipment used like the cuff of the sphygmomanometer, which is used for the blood pressure measurements. We use it to control bleeding from the tissues. And if used, and it's commonly used for orthopedic practice, and if you use it for the tumor, just elevate the limb. You don't have to do compression because it will make spread of the tumor. The third principle for biopsy is contaminate as little tissues as possible. So avoid transverse incisions. The deep incisions should be in one muscle. compartment rather than through an intermuscular brain, because if you do it through an intermuscular brain, you have contaminated both muscles. Also, avoid contamination of major neurovascular structures. Also, avoid contamination of the flaps on the side of the wound. Avoid minimal retractions, so to limit the tissue spread of the tumor tissues. This is a poorly placed transverse incision, so you have to make it longitudinal, not transverse. Because when we perform a biopsy, you have to go through the muscle itself and then resect part of the muscle with the resection later on. So you hide the biopsy tract through an expandable area, which is the muscle tract. Also, if you have a soft tissue extension with the tumor, you have to make a biopsy. However, sometimes when the bone is intact, you have to create a hole, a window in the bone to have biopsy from it. And this is another important step in the biopsy tract, because if you poorly perform this hole, you can result in fracture of the bone itself. So the hole should be round or longitudinally oval, so you minimize the stress concentration of the margins and prevent subsequent fractures, because fracture in malignant bone tumors may precludes or prevent limb salvage. So the patient can have an operation to save his limb. You, by your biopsy, have aborted his chances in having limb salvage. This is the appearance of the track or the window that we make. So it's concentrated, and it should not be rectangular, so it will have stress concentration. Like in this example, perform biopsy and the patient fractured later on. After taking a biopsy and performing the diagnosis, we have a principle for management of bone tumors. This is a general outline of management that will be discussed separately with each of the lectures later on. It's a multidisciplinary team approach, so it's not just an orthopedic surgeon. You have to have an efficient medical oncologist, you have to have an efficient musculoskeletal radiologist, and you have an efficient musculoskeletal radiologist. This will help you in the diagnosis and the management of bone tumors. If you have a benign asymptomatic tumor, if you are certain it's benign, just observe. If in doubt, perform a biopsy. If you have a benign symptomatic or progressively growing lesion, you have to make a biopsy, then you have excision or curettage. If you're suspecting it's a malignant tumor, you have to make a diagnostic workup like we mentioned before, perform staging, and the choices of treatment include amputation, limb sparing surgery, adjuvant therapy including chemo and radiotherapy. The chemotherapy is used not to kill the primary tumor, but to make it shrink and smaller in size. You cannot control the primary tumor by chemotherapy except with certain cases of early Ewing sarcoma. The main role of the chemotherapy is to control the macroscopic spread, so you prevent distant metastasis. Usually the chemotherapy protocols have multiple medications given through a central venous line and are given in cycles, different cycles of chemotherapy, up to 6 chemotherapy, and takes more than 1 year to finish this. We have two forms of chemotherapy. We have the neoadjuvant chemotherapy, which is the chemotherapy cycles given before surgery, and the adjuvant chemotherapy, the chemotherapy cycles given after surgery. Radiation can be used in the management of bone tumors to lessen or lower the incidence of local recurrence. It can be used instead of surgeries in areas where it's too risky to make resection or complicated or irresectable areas. However, radiation is not without complications, can result in skin damage, muscle scarring, and joint flexibility loss, can cause the damage of the nearby organs. For example, if you're radiated close to the liver, will cause radiation hepatitis, close to the lung, radiation pneumonitis or lung collapse and fibrosis. If close to the brain, encephalopathy, should not be taken lightly. Also, if irradiated, a gross plate in a child will result in gloss arrest. And if irradiated, assumingly benign lesion, like for example germ cell tumor, it can undergo secondary cancer like osteosarcoma or malignant chondrosarcoma induced by radiation. This is summary for the nature of the tumors. Benign tumors aggressive. Aggressive benign tumors like germ cell chondroblastoma and osteoblastoma. This is an X-ray showing the lytic lesion in the cortex of the femur with extensive periosteal reaction solid. This is what comes to this tumor, and when it comes to affect the posterior aspect of the spine. This is the form of cartilaginous lesions, famous by the presence of calcification. This is the osteochondron, which is a growth on the surface of the bone with the medulla continuous with the medulla of the native bone and cortex continuous with the cortex with a cartilaginous cap. We will discuss this later on. Fibrous lesions, cystic lesion, either unicameral or monocyst. All this will be discussed in details in the upcoming lectures. Thank you for your attention.